Okay, today we'll talk about myasthenia gravis and neuromuscular disorders, having a lot of various presentations and sometimes challenging in the emergency department. Here is a picture of Riyadh during the winter time. It's like a fantasy Photoshop picture to have, inshallah, we are praying to have 10 centimeters snowfall during the winter. And here is my picture in the winter, enjoying the cold weather and sitting happily at night. I will go to my camp, I'll get some fire there and make coffee and tea and enjoy the cold weather. Myasthenia gravis. I have a case here, 30 years old male, previously healthy, never had any medical problems before. He was a truck driver, driving in the highway, at which then he developed some symptoms. He started to have visual blurring, diplopia, he was unable to see, he has some shortness of breath, very vague presentations. He pulled over, he was really smart, he pulled over and called help. The police arrived, ambulance was called, and patient was taken to the hospital. We met this patient in the emergency department. There was some difficult language barrier. We got some translation, and he really confirmed that he had some history of weakness and numbness in his lower legs for almost like a week. But at that day, when he was driving, he started to have new visual symptoms. On arrival, he was afebrile with a heart rate of 110, blood pressure 130/70, breathing normally with no respiratory distress. But he was anxious actually, and a clinical examination revealed no muscular wasting and having an average body build. His neck examination was normal. His face examination confirmed ptosis more on the left side, but with the normal pupil examination and normal endoscopy. His neuro examination confirmed decreased power in the lower limb, 3 out of 5. Other systemic examinations, it was really unremarkable. And here's the X-ray. Patient had blood investigations, has the ACG, chest X-ray, everything is done, fluid started, and the radiologist called us and he said, guys, we have a superior mediastinal, widening. There is a widening of the superior mediastinum. The X-ray confirmed the pathology in the superior mediastinum was real, and you have to go for CT. CT scan was done for the patient, and it confirmed a smooth, homogeneous mass in the superior mediastinum. There was some lobulation of the mass. Really, it's really a smooth structural mass. Very suggestive of a neoplasm. In a summary, this is a 30 years old male truck driver, previously healthy, started to have weakness for 1 week associated with diplopia and visual blurring. He had a little bit of dyspnea for the last 1 week. His chest X-ray confirmed superior mediastinal mass. The CT scan more delineated the presence of superior mediastinal mass if the mass was lobulated and has some cystic compartment. So if you have these features associated with a smooth homogeneous mass in the superior mediastinum, immediately you have to remember the 4 T's. I learned this from the radiology department: thyroid, T-cell lymphoma, teratoma, and thymoma. The 4 T's of the superior mediastinum. Very famous acronym for the superior mediastinum mass. So now we have a patient with clinical findings, and we have a patient with radiological findings. So he has a thymoma, and he has features of myasthenia gravis. So this type of myasthenia gravis is called thymomatous myasthenia gravis. In crisis, first episode, thymomatous myasthenia gravis. Because sometimes we have patients in myasthenic crisis with no thymoma. Remember, so patient in myasthenic crisis, they may have a tumor, or they may have no neoplasm in the superior mediastinum. Myasthenia gravis is an autoimmune disease. It's a syndrome, affects many sites in the body, and it occurs about on a rate of 2.5 to 5 per 100,000 per year. Myasthenia gravis affects all ages and both genders, male and female, and it has no ethnicity discrimination. It's a chronic disease. 90% of the time, the patients will have chronic disease and they need to go for long-term therapy. What's happening is that those patients, they are forming autoantibodies attacking the neuromuscular junction. Autoantibodies attacking the neuromuscular junctions, and the disease variations, as you can see here, according to the age, has a bimodal peaks in the younger age group, and on the later age group, the bimodal weeks more in the male than female in the later age group. So male are more affected in their late age. Okay. So please remember, these numbers are very important. So 10% of the time, myasthenia gravis is associated with malignancy, like our patient. You know, he's having a tumor in his chest, and you will never know is it benign or malignant, because some of the tumor, they have aggressive malignant transformations, you know. And 10% of the myasthenia gravis are really refractory. They don't respond to therapy. You have to give them more doses, more plasmapheresis, more monoclonal antibodies, etc. 20% of myasthenia gravis, they affect only the eyes. They are ocular myasthenia gravis. You know, I have not seen a case like this one, but my colleagues mentioned to me that they have seen few cases with ocular manifestations and no skeletal weakness and no upper or lower limb weakness. 80% of the time, myasthenia gravis is a generalized disease, like our patient is having visual blurring, respiratory distress, and lower limb weakness. So he has all the features, and his CT scan confirmed the presence of thymoma in his chest wall. So this form of our patients we are having is an 80% of the time, and they are generalized myasthenia gravis. Okay, now someone will ask, if they have mass in their chest and they are symptomatic, what shall we do? Shall we operate the mass? Of course, you have to control the disease first, and then later on, when the disease is rather controlled, then you refer them to thoracic surgeons who will operate on them later on. So that's the second step. So step number 1, control the disease. Step number 2, resect the tumor. We'll talk about surgery and the benefit of surgery later on. So myasthenia gravis, again, subdivided into ocular and generalized according to the site. It can be subdivided also into mild, moderate, or severe. Did you notice that some patients with myasthenia gravis are intubated in the ICU on mechanical ventilator? These ones are the severe cases of myasthenia gravis. But some patients, they are, you know, they never had an respiratory distress and they are taking their therapy and going to the clinic. So some cases are mild, moderate, or severe. Okay. Remember, again, thymoma can be associated with thymus or may have no thymoma association with the disease. Non-thymomatous myasthenia gravis. Okay, so these are 2 types, and during the exam for fellows and residents, you may have questions about various types of this one. Okay, some scientists also added the autoantibodies in the classification, which is really not good, because the spectrum of the autoantibodies in myasthenia gravis is very controversial, not well really established. Maybe 2 antibodies are well known, the others are not really in the spectrum, so only for academic research. So please, classification using the antibodies is really not, because you know the autoantibodies by itself is a difficult, controversial aspect. So I will avoid that classification. Our patient is having the form of thymomatous myasthenia gravis. What's happening with the patient? Autoantibodies attacking the neuromuscular junction, you know. So normally, as you can see here on the left side, the acetylcholine receptors, you know, goes to the side, and then it's really got by the mechanism of excretion from the terminal ends. So the acetylcholine will be released from these vesicles into the junction and goes to the neuromuscular receptor, acetylcholine receptor at the junction. They bind, activate, create action potential, and then the impulse really travels, you know, through the neuromuscular junction. So this really very, very quick phenomena is really potentiated by the acetylcholine. So if there is an autoantibody really holding and binding to the receptors, what will happen is that you will have significant reduction in the receptor concentration, and also there is an evidence of anatomical pathological destruction. So you can see the shape here is rather more superficial with less clusteration of the acetylcholine receptors. Normally they are deep, they are really tremendous concentrations. So this is on the myasthenia gravis patients. Okay. Pathophysiology of myasthenia gravis is really very complex, not fully understood. There are many antibodies identified. Maybe 4 antibodies really well known right now. 2 of them, the acetylcholine receptor antibody and the MuSK antibodies, are really identified and investigated for the patients. The others are not really routinely done for the patients. It's a complex disease, not fully understood, and the patients, of course, they will have loss of the function of the acetylcholine receptors, decrease in their number, and pathological destructions of the end plate, of the neuromuscular end plate. 4 autoantibodies have been identified: acetylcholine receptor antibody, muscle-specific kinase tyrosine antibody, low-density lipoprotein receptor-like protein antibody, LRPR4, and arginine and cortactin antibody from the striated muscles. Anyhow, there are many autoantibodies, but number 1 and 2 are the well recognized and well established, and these are the one we request and we investigate usually in the hospital. Majority of the patients, they have positive acetylcholine receptor antibody 85% of the time, while 8% of the myasthenia gravis, they have the MuSK antibody. So the remainder, almost 7%, they have other antibodies, seronegative, as we call seronegative myasthenia gravis. They have other autoantibodies, and these are the one difficult to manage, chronic, etc. We will come to that later on. Okay. Thank you very much. Here is the end of the part 1, and this is my picture in the fantasy in the winter of Riyadh with a lot of snowfall. Thank you very much.